Good morning and welcome to the ACOEM webinar on guidelines for treating workplace hand, wrist, and forearm disorders. Today's program will discuss the methodology used to update the guidelines and also review diagnostic testing, pharmacologic treatment, non-operative treatment, and indications for surgery for a variety of disorders. Today's program is being recorded. This program is approved for 1.25 hours of CME and MOC credit. You received a verification form with today's instructions, or you can follow that link in the instructions to access the form. No certificates will be sent to you, but your transcript of this and other ACOEM educational programs can be viewed and printed from the ACOEM website. Members and non-members can view their transcripts directly from the website. Today's program consists of approximately 60 minutes of lecture followed by a Q&A period. Questions will be addressed as time permits, and we suggest you submit your questions early for consideration. We are only accepting questions electronically. On the screen, you can see how to open the question box and submit your questions. This educational activities presenter, Dr. Mark Melhorn, has disclosed he is a speaker for AAOS, ADEP, and ACOEM. Our other presenter and the webinar planners have indicated they have no disclosures. It is my pleasure to introduce our two presenters for today. Both have been involved in ACOEM's evidence-based practice hand, wrist, and forearm panel responsible for updating the practice guidelines. Dr. Mark Melhorn is Clinical Associate Professor, Section of Orthopedics, Department of Surgery at the University of Kansas School of Medicine and the Hand Center in Pennsylvania. As an occupational orthopedic surgeon, he specializes in hand and upper extremity disorders. Our second presenter is Dr. Felix Freshwater, who is Voluntary Professor of Surgery, University of Miami School of Medicine, and the Miami Institute of Hand and Microsurgery. Dr. Freshwater is a board-certified hand surgeon. At this time, it is my pleasure to turn the floor over to our first presenter, Dr. Mark Melhorn. Dr. Melhorn, you may begin.
Thank you. Good morning, everyone. We're going to go through the ACOEM guides for forearm, wrist, and hand, and as we move through the slides, you'll have the materials. We'll do some questions at the end, and as you type your questions, we may try to respond to those as we're going through the process. Again, another introductory slide. Today's topics, we're going to basically look at mechanism and diagnosis, diagnostic testing, treatment recommendations, the ACOEM algorithms, and then do example cases to kind of help tie the process together. Okay, one of the key things to understand with regard to the ACOEM guides, and in looking through either the book or the website process for the occupational medicine practice guides, is to understand the recommendations as they're put out. And I find this a little confusing sometimes because the same letters are used, A, B, C, for example, but what you need to understand is what follows the A, B, C. In general, A is considered strong, B is moderate, and C is recommended. But you need to read the rest of it to understand whether that is strongly recommended, moderately recommended, or just recommended. Then you'll notice in the lower left hand where the color is different, again, not recommended is still the letter C. B is moderately not recommended. A is strongly not recommended. In between these two is the in-between part called the ineffective or insufficient evidence. And basically, I look at this as what we currently have done in the past, which is basically consensus-based. A group of physicians get together and say, yes, this works, no, it doesn't work. And so you come up with this lack of evidence-based medicine, but still, things that we find tend to work. And that falls in the I category, but you need to read past the I, either recommended, not recommended, or no recommendation. Evidence-based medicine, as you know, is sort of the new buzzword in evidence-based medicine. One of the definitions that's being used now is a set of principles and methods intended to ensure that to the greatest extent possible, medical decisions, guidelines, and other types of policies are based on a consistent and good evidence, effectiveness, and benefit. The way I like to think of this or look at it is simply what I would like to have done for me if I was a patient, or what I should do for my patients when I'm their physician. Evidence-based medicine is not selecting an article to support your point of view. If you are good at Googling or reviewing articles, you can basically find an article that may support any position or point of view. The question is, what is the quality of that study? Is it simply a case report where a physician says, I get good results, this is how I do it? And so looking at several articles is key in the process. You need to read the abstracts, but you need to do it critically. And that's what the ACOEM Guides has tried to do for you. Kurt Hagman, who is the editor, has tried to go through and rate all of these articles for you. So by looking at the guides, you simply already know what the evidence shows, going back to that earlier slide, which is considered the evidence and recommendations of strong, moderate, recommended, insufficient, etc. That is an objective grading assessment of the entire body of literature done for you. Why are there guidelines? Well, the guidelines are here to stay, whether you like them or not. And when I do these courses and there are faculty and attendees present, there are mixed opinions as to whether they like them or not, but they're not going to go away. And as the government continues to step into the process, it will probably become more intrusive rather than less. The second is just the massive literature alone. For all of us to stay current in all of our different areas becomes quite challenging. And so by having a group of physicians or researchers go through, read the literature, summarize it, identify the good studies, and then put that in a book like the ACOEM Guides, that's actually very effective for us, so we aren't wasting time going through and trying to find items on our own. The second or third thing in the process is there really are relative few quality studies out there. And so when you come to an opinion, you have to weight the evidence of multiple studies and their relative value, and then combine that information to come up with a indication in the guides, again with the recommendations of A, B, C, and sufficient. The quality of studies are widely distributed. There are good and bad studies. There are good studies that were done but poorly done with regard to, say, the volume or number of people who are involved in the study. And so that gets us to the fifth. We all lack time. We're all fairly busy. It's difficult to read all the literature. And number 6 is many of us were not trained when we went to medical school and residency on how to do the grading. And so now the grading is outlined nicely for us with regard to the guides. It's printed, and it's in the first part of the book as you go through and read that. The methodology, any evidence-based guidelines, and there are several out there in addition to the ACOEM Guides, you need to understand what is the methodology. It should be published, it should be detailed, and it should be understandable. If it doesn't have those components, then we're back to consensus, and you really don't have what's considered an evidence-based guideline. Scientific variability or verifiable. Are the conclusions reasonable and appropriate? And then professionally appropriately trained, and are they credentialed? So obviously you don't want to have your mom and dad, who may not be physicians, doing the review and being the publisher of an evidence-based guideline. And the panel should be broadly based. So ACOEM has worked very hard at including internists, family physicians, occupational physicians, orthopedists in their group when they create the panel. So the panel is broad-based with the idea that this way the group will have read multiple articles that can be included into the process. So with that,
Dr. Melhorn,
yes.
Could I ask that you speak up a little bit?
Sure. Sorry.
Thank you.
With that group, with that process outlined, can you hear me better now? Good.
Yes.
Okay. The mechanism and the diagnosis are the next items in the process. In this process, we're looking at mechanism of injury. Obviously, you want the mechanism of injury to make sense relative to whatever the diagnosis or condition is. So, for example, if you have a fracture, you would expect to have some sort of history of trauma, fall component. So if you look at the left-hand column and you look at the mechanism of injury, you ask the patient, how did this occur? And they say, I fell on an outstretched hand. Well, then if you look in the right-hand column and you look at fractures, you would expect, if they fell on their hand, that they might have a fracture of a phalanx, a metacarpal. If the wrist was extended at the time and there was additional loading, they could have a scaphoid fracture, they could have a distal forearm fracture. And so mechanism of injury is an important thing to understand. Crush injuries often result in lacerations. Direct trauma could include such as a bite. Teeth marks or punching can occur. TFCC tears, also again common with falls. Direct trauma. Direct trauma is unusual for carpal tunnel, but it certainly is possible if they have associated swelling with regard to the wrist, or if the individual had pre-existing nerve entrapment, and then at the time the nerve becomes pinched due to the swelling. Again, going down through the list, if you look at a mechanism, crush injury, obviously diagnosis of crush injury on the right. A fall could cause a compartment syndrome again if the individual falls and breaks their ankle and they have swelling, then a compartment could occur. Pressure on extended digits, wrist sprain strain type component. Person is lifting a box, the box bends the wrist back, hyperextends the fingers, and then makes the wrist sprain strain. Extended use of a hammer in the hand, or if you use the hand as a hammer, or if you get hit by a ball or some object, it can result in a mallet finger. Compression neuropathies fall in the ulnar nerve, radial nerve, and of course you can have an underlying bone lesion that may be causing some of that compression in the area. When you think about carpal tunnel, ulnar nerve, radial nerve, flexor tendon entrapment, associated things to consider: pregnancy, hypothyroidism, obesity, amyloidosis, rheumatoid arthritis, osteoarthritis, gout. Some consider individuals to be at risk due to a small carpal canal, and of course the majority of nerve entrapments probably fall into the idiopathic category. For extensor tenosynovitis, TFCC tears, Kienbach's disease, there is again some association with diabetes, rheumatoid arthritis, the group we went over. And of course, just age-related degenerative tears, pretty common with regard to TFCC. Frequently, I will see a patient who complains of TFCC symptoms, although they have a minimal traumatic event, and you do the MRI, or they're sent to you with the MRI, which is interpreted as positive in a tear, and yet clinically they just don't fit a TFCC pattern that you would want to consider surgery. I do the MRI of the other wrist, and lo and behold, they have exactly the same pattern in the opposite extremity, which is entirely asymptomatic. So when we get to the case examples, that might raise an interesting question as to whether you would consider that work compensable or not with regard to the injury. Heredity is an important component for arthritis. Vibration is important when considering hand-arm vibration syndrome. The nonspecific activity or the nonspecific pain component, I like to label that I hurt in the workplace. This is the person who shows up and says they have a workplace injury and that they hurt, and yet you do the clinical examination and testing studies, x-rays, nerve conduction studies, everything is normal. And that's a difficult group to deal with. Unknown mechanisms, people come in and they say, well, you know, I was just at work, I was doing my regular job, and I started having increasing pain or discomfort. Some people will associate ganglion cysts to that unknown etiology group, Kienbach's and AVN. Other conditions to consider. So if you're looking at diagnostic symptoms and signs, carpal tunnel criteria, most of us would consider individuals who have numbness or tingling or burning sensation or weakness that they describe in their first 3 radial digits. As you know, hand surgeons, we prefer the term thumb index in the middle rather than calling it a digit, because then you always get confused as to is the index the first digit or is it the thumb. Tingling after sustained hand use is often described described tingling after using the keyboard. I have a lot of patients who come in and their first statement is, Dr. Melhorn, my job caused my carpal tunnel, and I'm on the keyboard all day long. Well, the interesting thing is we go along, you'll find that there are no good studies at this point that indicate that keyboard activity is a high risk for proximal radiating pain. People who have symptoms involving the hand and wrist, and they'll say that it starts in their wrist and the pain will go all the way up to their shoulder, is non-anatomical, and that certainly makes life more challenging for the treating physician. They sometimes will complain subjectively of swelling, but when you actually measure their hand or forearm circumference, there is no swelling. It may be that the nerve is being pinched enough that they get a sensation of swelling even though there isn't physical swelling present. They commonly describe loss of grip, numbness and tingling with the loss of grip, and I drop things. Looking at those symptoms and then going over and trying to match that to clinical signs, obviously if they have decreased thumb abduction or grip strength, or they have thenar loss, which is a late sign, that is somewhat confirmatory. Most of the patients I see now have not waited until they have thenar loss to come in and complain. Most people are being seen earlier, and so thenar atrophy I don't think is as common in the work comp as it used to be. Sometimes there'll be a temperature sensation loss, but that's unusual. CATS diagrams I think are very important. We call them white drawings in our office because if you use the term pain drawing, I think that provides an inappropriate connotation. It's simply a communication tool, and then we can score that. Vibratory sensation can be helpful, but it's not objective from the standpoint that you're relying upon the individual to tell you if they can or cannot feel. The same is true for two-point and monofilament. Those are all helpful items, obviously, to occur. Compression testing with the wrist, phalanges, tenelles. Interestingly, when I grew up and went through medical school, these were all considered to be the gold standard, but now that we've actually done studies, they really are low in specificity and in sensitivity. But I think they're helpful when they're used in composite, and you're looking at all of the components together. Does the history fit? Does the clinical examination fit? Does the subjective complaints fit? And any response to treatment that you've done, does that fit? All right, moving from carpal tunnel now to TFCC. We kind of discussed that a little bit earlier. Wrist pain with motion is a common complaint. The recovery curve. If you have a TFCC acute injury, you would expect some gradual improvement with time, but they may have some residual loss. If that residual loss persists, then additional studies such as MRI can be helpful. But again, the normal population, probably about 10 to 14%, probably have some TFCC degenerative component, and so when you do an MRI or an arthrogram MRI, it's going to show a tear.
Mark?
Yes.
We have a couple of questions.
Okay.
Could you elaborate on, number one, what does TFCC mean, and number two, explain what ulnar positive, ulnar negative, ulnar minus, ulnar plus mean?
Yes, thanks for keeping an eye on that for me. The TFCC is triangular fibrocartilage complex, and the way to think of this is if you look at your wrist and you look at the radial and ulnar wrist, right at the wrist crease, looking down on the dorsal part or back part of your hand and wrist, between those two bones, there is a band that holds the radius and ulna together, so as you supinate or pronate, palm up, palm down, those structures are held together. That TFCC is kind of like a meniscus of the wrist, just like the knee. Most of you probably are familiar with the meniscus in the knee that gets torn in sports and athletic injuries, and so this is the same type of process. The interesting thing about the TFCC is it's very thin in the center, and it's fairly thick around the outside or the edge, which is a little bit different than the TFCC in the knee area. And so that's one thing. And the second question was what, Felix?
Ulnar positive, ulnar negative, ulnar plus, ulnar minus.
Sure.
Variant.
One of the things that you do is we'll do an X-ray with regard to the wrist, and it's important that you take an X-ray of both wrists so you can compare the two. When you do the X-ray, the ulnar styloid and the flat part of the ulna, not the tip of the ulnar styloid, but the flat part, should basically be about even with the radius. If it's not, then it's either an ulnar minus, meaning it's shorter, or it's an ulnar plus, which means it's longer. The feeling is that an ulnar plus will cause some sort of bone impaction or rubbing on the small carpal bones in the wrist and will increase the likelihood of a TFCC tear, and or also it's felt may increase the likelihood of avascular necrosis of the lunate. And so that's a test that you can do, or an examination that will give you some additional insight. On the TFCC now, as you look at the conditions and signs on the right, oftentimes the patient will complain of a snap or a click in the wrist. And I find ulnar side wrist pain to be kind of like low back pain. It's very difficult to diagnose. It's very difficult to treat. And the symptoms tend to be chronic, but oftentimes can be self-limiting unless there's a high-level traumatic injury that precipitated the onset of symptoms. So that gets us sort of to the next list, wrist sprain strain. It's not uncommon to have pain after trauma. The capsular stretch type symptoms will be present. Gradual improvement over a 4 to 6 week period with modification to activities and or splinting may help. Crush components, severe pain after trauma. Obviously, if you get your hand caught between a forklift and a dumpster, you're going to have intense pain. The key to look for is neurovascular compromise, and then whether or not the compartment gets tense, because obviously you want to avoid a compartment syndrome. Kienbock's disease, as we talked about, is a progressive wrist pain type pattern. I think that a lot of people develop some degenerative change in their lunate over time. Not all of those end up having pain that then precipitates them coming to a physician, getting x-rays or MRIs, and then those are interpreted as Kienbock's. Kienbock's can be graded into 4 levels, and we'll not go through all those in detail, but basically most patients who are now getting an MRI, the radiologists tend to overread those just a little bit and indicate, well, there's some sclerotic change that may be early Kienbock. But when you follow those people along, most of them don't end up having gradual progression over time. And so I like to see a patient with radiographic changes that are occurring over time before I actually label it as Kienbock, even though the MRI may say there's some questionable early change. A mallet finger, I think most of us understand that. It's when you strike the end of the finger trying to maintain it straight, and the extensor tendon pops off the distal phalanx, and the finger droops and it won't fully extend. And this can happen with just simple activities where somebody will be scrubbing the top of a table counter with a sponge, and they'll try to remove a bump or a greasy spot. It'll catch and snap and pop, and the finger droops. The important thing is to recognize that early, get them into the appropriate splint. Most will heal. So it's the late diagnosis that becomes challenging. Flexor tendon entrapment, probably a trigger finger for lack of a better term, or what most of us call pain, catching, locking is the complaint. You'll often feel on the examination palm side swelling over the metacarpal head, and when you flex and extend or put pressure on that, you'll feel the tendon click as it slides through the A1 pulley. Extensor tendon tenosynovitis is almost always considered first dorsal compartment, which is Finkelstein's Decker veins. Decker veins is the doctor who described it. Finkelstein's is the test that's performed. The easy way to think of Finkelstein's test is simply have the patient put their thumb in the palm of their hand, bend the fingers over the thumb, and then gently move the wrist ulnarly or away from the thumb, and then they'll complain of pain right in that spot. You can also tap right over that area when you do it, and that may accentuate their symptoms and helps confirm the diagnosis. Ulnar nerve entrapment, less common than median, but certainly is possible. When people come in and they say they have tingling, and again it says 4th and 5th digit, but the preferred term would be ring and little finger. That's usually ulnar nerve elbow. You can do a flexion test where you bend the elbow up, and that may increase their numbness symptoms in the ring and little. You can tap or percuss over the ulnar nerve at the elbow, which may accentuate their symptoms. Radial nerve entrapment can occur 2 locations. First is at the wrist, first dorsal compartment area, and they usually complain of heaviness or a burning sensation over the dorsal aspect of the thumb and the index finger in the hand area. That can be accentuated by tapping over that sensory branch right at the wrist, about the level of the first dorsal compartment. The second is at the elbow over the lateral aspect. People tend to complain of, again, an ache or a burn over the elbow, not directly over the lateral epicondyle. So people can have a lateral epicondylitis, tenderness on the epicondyle, but if they're complaining of this heaviness or burning sensation in the proximal part of the forearm, that may be radial nerve elbow. And that may explain if you do an injection for the lateral epicondylitis, and they say their pain on the tip of the bone on the elbow is gone, but their arm still hurts, they may have this radial nerve elbow component. And then, of course, the last and favorite for all of us, non-specific hand, wrist, forearm pain. And as I described earlier, my favorite label for that is I hurt in the workplace. And putting down pain but not putting down a specific diagnosis is acceptable and I think is desirable so that people don't get mislabeled in the process.
Dr. Melhorn, if you could continue to speak up a little bit more.
Okay, I'll keep working on it. Is that better?
Thank you. That is better.
All right, sorry. Diagnostic testing, 3rd edition. Okay, so this is where we're going to go through the ACOEM recommendations and evidence as to whether or not a condition and a test are linked, and if they are linked, whether they should or should not be done. And the key, again, is at the very top where we're putting down diagnostic testing recommendations. So this is considered in that first group, which would be either strongly recommended, moderately recommended, or recommended. Still using the letters A, B, or C. The I's that you see at the right fall into that category of insufficient, and again, there's 3 categories of insufficient. All are consensus-based, recommended, no recommendation, not recommended. So, with that background, let's go through this concept again. First is, let's look at carpal tunnel. For carpal tunnel, EDS stands for electrodiagnostic testing. And in a work comp scenario, it is recommended that you get an EDS to confirm the diagnosis prior to surgery. The letter C simply means recommended. Now, that's not strongly or moderately recommended based on the literature, it's just recommended. Why is that? Well, if I have a patient who's a nurse who's Blue Cross Blue Shield and has classic carpal tunnel symptoms, I'm unlikely to get a nerve test unless she feels she wants that done. In a work comp scenario, though, I will get the nerve test, and the reason is more for medical legal documentation and issues with regard to follow-up care and or subsequent nerve entrapments in the future. So this would be a good example of where care in a workers' comp scenario or setting is a little bit different than in the traditional healthcare setting. But I offer that option in the traditional healthcare setting and then have the patient help decide whether they would like to do that or not. Ulnar nerve entrapment, EDS, insufficient evidence, okay? Interestingly, most of us would probably still do the nerve conduction study for the ulnar nerve entrapment. And again, in a work comp scenario, I recommend that. Radial nerve entrapment, again, insufficient evidence. Now the question becomes, when you talk about EDS, are you talking about just the NCT, which is the nerve conduction study, or are you talking about the electromyographic study, or are you talking about both? The literature doesn't really help us in separating those two out to know which is the best approach. My current feeling is that in most cases that I think are straightforward, the clinical examination, the history, all are supportive of a classic carpal tunnel or nerve entrapment. I oftentimes will only do the NCT and will not do the EMG. And the reason for that is that the NCT will change first. The EMG usually changes late. And as I discussed previously, most of these patients are coming in early prior to thenar atrophy, and therefore most electromyographic tests will be normal, although the NCT will be abnormal. If I have an unusual case that has multiple nerve entrapments or has symptoms to the shoulder, or I'm confused, and I use that in quotation marks, I can't understand or explain why they're having the symptoms they're having, then I will order both the NCT and the EMG. Foreign body. If you have a foreign body, ultrasound, insufficient evidence. Some people like ultrasounds, others don't. My personal experience is I don't do ultrasounds for foreign body. TFCC tears. Plain x-rays, as we talked about before, and as Felix pointed out, can be very helpful, particularly when you're looking for an ulnar plus or ulnar minus. MRIs can be helpful, and so can the MRA, which is an MRI with arthrogram where you do the injection. Again, though, remember, tears as you get older are fairly common. Leakage to the area is not uncommon, and if you have any questions, you can always do the other side. Joint effusions. I find this one interesting. The science basically says insufficient evidence to aspirate. But, you know, the treatment of choice for a joint effusion is basically aspirate it, get a gram stain culture, and look for crystals. Because once you get those pieces of information, it basically will answer the question or at least give you insight as to why they have a joint effusion. So although it says insufficient, I consider the census to be recommended. Suspected rheumatoid disease, again, insufficient evidence, but again, you can make the diagnosis by serology and or aspiration of a joint in the process. Crush injuries, again, recommended, but with eyes, and all these on this page are eyes, so that means that it's basically consensus-driven. X-rays are helpful. MRI may be helpful. A CT if you think it's bone. Rule out fractures. Plain films are very effective. Scaphoid views, you can get additional scaphoid views that may be helpful. If you think you have an occult scaphoid fracture, you can look at a MRI or a bone scan. You can even do a CT. Distal forearm complex injuries, MRIs if you're looking at the soft tissue. If you want to delineate the bone anatomy, CT. Dislocations show up on plain films. And Kienbox we talked about already, either X-ray or MRI or a combination of both. Going down the list, osteoarthritis, laceration, mallet finger, scaphoid fracture, ganglion, persistent non-pain, paresthesias, an unclear diagnosis. All of these are basically insufficient, but would be considered agreeable if you document why based on consensus information. What tests are not recommended? Now, going on the other side of this 9-level recommendation, now we're on the bottom half where it's not recommended. Nerve conduction studies, initial evaluation. So if the patient comes in with carpal tunnel symptomatology, your first step is not to turn out and say, you need an NCT, thanks for coming in, we'll get the test. It's often recommended that the injection be done prior to the NCT test. In this case, the answer is no. You probably should get the nerve test before you do your injection. Ultrasound is not helpful for diagnosing mallet fingers, tough fractures, or phalangeal metacarpal fractures. MRIs are not appropriate for a tough fracture, phalangeal fractures, or metacarpal fractures. And the reason for this is that the plain films will give you the diagnosis here. You don't need the more expensive tests that aren't going to help. X-rays, routine non-operative treatment of fifth metacarpal fractures, not recommended. I'm not sure I understand that. If you have a fracture and you need to assess fracture alignment and healing, it would seem to me that you need an X-ray to do that. X-ray is not routinely required for a ganglion. Again, these are all in the insufficient, but they're on the lower side. So I think one-time X-ray of an area for a ganglion to confirm there are no other bone issues is fine. Repeated films probably are not necessary. Bone scans are not needed for tough fractures, for phalangeal, and for metacarpal fractures. If you wait 2 weeks, repeat your X-ray, you'll oftentimes see a periosteal bone reaction if you couldn't see the fracture on the initial films. Now, what type of EDS testing? Basically, the commercial products that you put on a pad or adjust and then hook them up and they run and then they send that off to some company and then you get a report back are not recommended. Most studies should probably be done by someone who is experienced or has been trained in doing standard NCT EMG testing. Electrodiagnostic testing, says hand vibration syndrome, it's not required. I would agree for the hand vibration syndrome part, but the problem is that frequently these people have carpal tunnel or nerve entrapments associated with their HAVS, and so I think that the EDS test is appropriate if you have that combination pattern. Ultrasound's not required to diagnose carpal tunnel, ulnar nerve entrapment. Evaluation of chronic wrist pain, suspected ganglion, it's not recommended, but I do know that people who do that. MRI for diagnosis of carpal tunnel and ulnar nerve. If you haven't made the diagnosis prior to that, returning for an MRI or obtaining an MRI to do that is probably not appropriate. Wrist pain with suspected ganglion. If the wrist pain you think is from the ganglion, not the MRI. If the wrist pain is from something else and you can't determine it, such as a TFCC component, then I think an MRI would be reasonable to do. Not recommended for hand vibration syndrome or all of these other tests that have been done over time. HAVS is primarily a clinical diagnosis. Deep breath, treatment recommendations. So again, going through the process, we have the ABC component, treatment for carpal tunnel. Steroid injection, subacute chronic, is strongly recommended. Surgical release, strongly recommended either in the urgent care or emergent care type component. That would be if you have a traumatic entrapment carpal component and compressions occurring. Treatment failure, so if you have done non-operative treatment, non-steroidal anti-inflammatories, steroid injection, symptoms still persist, surgical release is A. Endoscopic or open, B. So there really isn't a clear-cut benefit for one or the other, endoscopic versus open. And the interesting thing here is that most of the endoscopic studies that were done that reported improvement were done compared to the traditional large, long, open surgical procedure. The Hand Society currently recommends the mini palm incision process, and so no studies have really been done to compare the mini palm to the endoscopic, and therefore the feeling is that probably they're about the same, and your likelihood of return to work and long-term benefits are essentially the same. However, endoscopic carpal tunnel has a much higher risk for injury and complications, and it also costs more. Post-op non-steroidal anti-inflammatories are recommended. Post-op acetaminophen is a C, which is recommended, and then limited post-op opioids, insufficient evidence. But I can tell you that I give most of my patients a small script, 10 of a narcotic pain medication, and have them take 1 or 2 the first day or 2, and that's usually it. Splinting. Splinting is recommended with regard to the treatment. I prefer splints nights only, not days. I find people tend to fight against the splints during the day. Oral steroids, it actually is moderately recommended based on the science. I am uncomfortable giving somebody an oral steroid in the process, even if they have chronic symptoms and they've declined injections. I would tend to look at some sort of cream to be massaged onto the wrist instead of oral steroids by mouth. Other products basically are in the C category, which are a knife light ultrasound. And so although there have been some benefits, not enough that I would consider those mainline. Other things that are recommended, but just the science is not there to give us enough. Most of us probably do these. We talk about some sort of work modifications or restrictions. The feeling is that probably power, grip, and vibratory are the key, and repetition may be part of the process. So limiting or lowering those through the day may be helpful. I think education is important for every patient. I like exercises before and after for the patients. We've talked about the injections previously. Lidocaine patches, some people like. I haven't found them very helpful. Massage maybe helps, but it's not that big a benefit. Biopsy of the abnormal synovium. You know, if I have somebody who's on renal, has renal dialysis or has kidney dysfunction, or they have a question about rheumatoid arthritis, or there's a question about atypical microbacterium being a contributing component, I'll biopsy the synovium, but normally I don't send the synovium for a biopsy. Pre-incisional antibiotics for high-risk patients. So if you have a diabetic, has other conditions, concerns, and you want to do antibiotic prior to, that's reasonable. And then I think most carpal tunnel surgeries are now done under local or regional anesthesia. The risks involved with the general anesthesia, I don't think warrant doing that. Okay, what things are not recommended? And in the not recommended, internal neurolysis is strongly not recommended. And most studies actually show that if you do an internal neurolysis, most likely you actually increase the scarring, you increase the likelihood of reoccurrence, and you increase the complications. Epidurectomy, same type of concept. Flexor retinaculum lengthening, also bursa, preservation, superficial nerve sparing incision, ulnar surgical approach, diuretics without fluid retention. None of these things have been proven to be of any benefit, add cost, and add complications and complexity to the process. Not recommended. Non-steroidal anti-inflammatories is a primary treatment. And again, it's barely not recommended, but my feeling is I oftentimes will do that. Some people do get better, and so I would recommend that. Vitamins without a vitamin deficiency is not recommended, but again, it's the weakest form of not recommended. And so I think that if in today's society people often do not get a good diet, a regular vitamin once a day is probably a reasonable option to consider. I have patients who love magnets, but there's no science to show magnets help. Low-level laser therapy, no recommendation that shows that helps. And ACOEM did a study a while back where they looked at low-level laser with batteries in and with batteries out, and the group with the batteries out had a better outcome than the group with the batteries in. So you can draw your own conclusion if the batteries are not in, whether or not the laser was working. Therapeutic touch, not recommended, but I think all of us like massage, so some people enjoy that. IM injections, I again try to avoid systemic treatment for this condition, and then botulism injections are not recommended at this time. Not recommended routine use of opioids, spinal manipulation, and routine use of massage. Instruments to monitor progress, exercise for chronic CTS. There was 1 or 2 studies that showed yoga might help. I think being physically active and educating the patient is reasonable, so I would suggest yoga if people want to think of that. We've talked about the vitamins. Again, there's probably not strong evidence, but it doesn't hurt. Acupuncture, no benefit. Biofeedback, no benefit. Wrist manipulation, that would be chiropractic care. Iontophoresis, phonophoresis, and insulin injections, not recommended. TFCC tear, shifting the gears here a little bit. What is recommended, but again, this is in the category of consensus, education for selected patients, relative rest, which would be modification of activities. A splint may help to reduce rotation in the acute or subacute phase, but in the chronic phase, I don't think it's helpful. Heat and cool helps, decreases their symptoms. Non-steroidal anti-inflammatories are appropriate. Surgical repair, if they're unstable, they have associated fractures, there's no resolution of symptoms at 4 to 6 weeks, those are all possibilities. But even when you do arthroscopy for a TFCC tear, you debride the tear. Some people do great, others continue to have symptoms. Ulnar shortening and wafer procedures. These are discussed for the ulnar positive variants. This is a way of shortening that ulna with the idea to take that pressure off with regard to the area. I'm not excited about those because the complications are fairly high with those procedures. Now we have a question that popped up here that says, evidence for nerve stretching for treatment of CTS. Right now there is not any good evidence that shows that nerve stretching or nerve gliding exercises are beneficial. But I would consider those to be in the insufficient and recommended category. I like nerve gliding exercises. I give my patients exercises to do those. I do those exercises myself. And so I think that's probably a good recommendation in that case. Other things, for compartment syndromes, Fasciotomy, hyperbaric oxygen, and other surgical procedures is either recommended or on the insufficient recommended. And from a hand surgeon's point of view, I can tell you that if I have a patient with a crush injury and they have a compartment syndrome, I'm going to do a fasciotomy because my medical legal liability is pretty high if I don't do a fasciotomy. And they end up with a contracture, and the flexor muscle groups are all contracted, and they cannot extend the fingers of their hand. Rest and elevation, insufficient, but again, it depends on the severity of the compartment. I mean, if they have a bruise to their forearm where they were bumped by a box or something, and it's limited, it's small, it's a hematoma component, it's not causing neuropraxia distally, there's no neurovascular loss, there is no decrease in arterial component, and they're not complaining of progression of symptoms, then yeah, I will rest those. I may apply ice, which is the next item. I may give them a non-steroidal anti-inflammatory, although some people feel that if you give them aspirin, for example, that will increase the bleeding, so I may not do that in the initial period. Opioids in selected cases, again, I would tend to avoid, and partly because the opioid may hide a true compartment that's progressive, and you want to know that in advance. Education, Keen box, selected patients, self-application of ice, splints, non-steroidal, topical medications. Again, opioids limited. Surgical intervention, 6 to 8 weeks is an option. Keen box is extremely difficult to treat, and the surgical interventions are multiple, and none of which are great with regard to their outcome. Wrist sprain strains, non-steroidal anti-inflammatories, self-application of heat, education, rest, all fall in the group that are probably beneficial. Splints may help, acetaminophen may help, opioids for night use only. I don't like opioids for sleep. That's my personal opinion. Mallet finger, again, this is in the insufficient. So if you'll notice the trend here, a lot of what we have at this point is consensus. There isn't a lot of good evidence-based medicine to support many of the things that we do. So splinting and extension, I think, definitely helps. Surgery, K-wire fixation, if it's more than a third of the articular surface, or if you can't maintain with a splint, those are all reasonable to do. Flexor tendon entrapment, commonly called trigger finger. Steroid injections definitely do help. Open release, and I use a small incision in the palm under local, and they do fantastic. I do not do the needle stab technique where you just go in and take a needle and try to slide it up and stick that. I've seen too many flexor tendons cut when that's done. It increases my business, but those are patients I just as soon not see. Splints may help if they decline the injection. Extensor compartment, this is primarily a Decker veins tendonitis component. And again, non-steroidals do seem to help some. Modification to tasks, maybe. Education, maybe. Thumb spike, maybe. Iontophoresis, maybe. Glucocorticoid injections, maybe. Even surgical release, maybe. But I can tell you that in the patients that I do and do the surgery, most get better. But if you look at the literature, insufficient evidence. Ulnar nerve entrapment wrist, removed from causative job tasks. I like this one because we don't have good evidence of what the causative job task is. But the literature says that if you take people out of the tasks, they have less symptoms. So I won't disagree with that, but it doesn't tell me that that's actually the cause. Education is key. Modification to activities may be helpful, keeping the wrist neutral. And surgical decompression may be helpful if they fail the above improvements. Radial nerve, again, this wrist or elbow, same kind of concept. Task modification or removal, education, splinting may help. Surgical release is an option. Non-specific hand pain, education, relative rest, and that would be for high ergonomic exposures. Obviously, stone quarry drill operator and chainsaw logger are two jobs I would consider to be high ergonomic exposures. And in those cases, I would say, yes, modification activity is reasonable. But somebody who is a greeter at a store, and they walk in, you walk in, and they say, hey, Dr. Milhorn, good to see you today. Grab yourself a cart and fill it up. And that's their entire job activity. That would be a relative low-risk ergonomic job. Scaphoid fractures, immobilization, less than 1 millimeter displaced, non-oblique, not proximal third, casting. Hand surgeons are really pushing now those to be percutaneously pinned or screwed in this case, and so I think the literature is going to change over time for even non-displaced fractures because it can be done on an outpatient basis. The recovery is great. People can get back in fairly quickly. And so if you look at the second item, surgical interventions listed, education is helpful. Collies, cast, splint, x-rays, non-steroidal for pain, and therapy often not required, particularly with the newer techniques that's done. In the old days, when you put them in a cast for 3 or 4 months, they oftentimes did need. Distal phalangeal fractures, education. I don't routinely like to get the hematoma off underneath the subungual component. A lot of times when they do that, people will actually penetrate through and damage the nail bed or matrix area, and then you have more problems. Non-steroidal anti-inflammatory, if it's open, tetanus booster if they need it. I frequently will splint to protect the area, which I think is a good recommendation. Middle, proximal phalangeal fractures, these are very difficult to treat. They don't do very well. Splinting and bracing may help if you have a fifth metacarpal, but if you have any rotatory component in the middle or proximal phalangeal fracture, send it to a hand surgeon and make his or her life miserable because they will end up with some stiffness and decrease in range of motion. Closed reduction, metacarpal fractures, particularly boxer's fractures, right little finger, left little finger, those can be done and stabilized fairly well. Phalangeal fractures, again, are very difficult. Operative treatment, if it's intercondylar, if there's malrotation, base of the proximal metacarpal, if it's a Bennett's and Rolando's, these are specific descriptions at the base of the thumb and the little finger. These are unstable fractures, and you want to get those people out and seen as soon as possible for surgery. Immobilization and distal non-displaced fractures, 3 weeks. They actually do pretty well, and I like to immobilize most of mine. Functional cast bracing or splinting for non-displaced fractures. You need to protect them so that they can't re-injure it, but allowing them movement actually probably improves the healing and speeds the process. For pain, it certainly is reasonable to look at non-steroidal anti-inflammatories, manipulation, dynamic traction devices. They're actually recommended, but I don't do those. Dynamic reduction, if you're talking about the time of surgery, I think that's reasonable, and I do a hematoma block for pain control after the surgery. Ganglion cysts, no treatment if it's an acute type process and symptomatic. I think that actually you need to educate them. Sometimes heat or cool will help. If they do persist, aspiration is reasonable. If the pain interferes with activities or they bump it at work, surgical excision is reasonable. But I tell people high reoccurrence rates. I do all mine open, not arthroscopically. Again, I think very high complication rates. Steroids orally, I don't recommend, but injection-wise is certainly reasonable. Splinting afterwards, not sure if it helps. And what you inject in there probably doesn't make as much importance as actually just puncturing the sac. Multiple cyst is not recommended, so you don't do this multiple times. And again, specific sclerosing agents are not recommended. Hand-arm vibration syndrome, work restrictions, low frequency, high amplitude vibrations, limit cold exposure, education is key. Some talk about channel blockers and other components, but the benefit of that has been limited. Lacerations, education is important. Wound care is important. Wash and clean the area, sterile technique, topical antibiotics, oral antibiotics, a digital block, regional block, whatever is appropriate. You want to be very careful about epinephrine in the digits so that you don't cause one of the arteries to clot off, and then you're in trouble. Wounds less than 2 centimeters and without tension probably can be done by secondary healing if they're fairly small. And you can use adhesive tapes and straps and other components. Otherwise, small sutures is a good way to go. Suture repair, no specific technique seems to be better than the other, so it's a surgeon's preference. Immediate surgical referral for nerve injury is probably appropriate. Complications, infected wounds, they're out 24, 72 hours. Then it makes it more challenging. Non-steroidals for pain are reasonable. Short course of opioids, I think, are also reasonable. Human bites, education is key. Evaluate for blood-borne risk pathogens. Antibiotics are certainly appropriate for dog. Human bites actually probably the worst, particularly at the MCP joint, and so you need to get them on an antibiotic and wash and irrigate the area. And these are all, again, recommended by consensus, not by the actual literature if you look at the process. Waiting, here we go. Osteoarthritis, education and splinting, exercise, self-applying heat components, non-steroidal anti-inflammatories. These are all things that are pretty much either recommended or consensus in nature. Acetaminophen in the process. I don't routinely do the opioid for severe osteoarthritic components. I try to look at therapy, yoga, other components, maybe an injection, but I don't like steroids. Osteoarthritis, the CMC joint or trapezius metacarpal joint, either a fusion. I like to do a hematoma distraction arthroplasty, which I think works very well. Women do not like to have joints made stiff. Ergonomic interventions, high force, high reps are probably the key in life that you want to try to avoid. The problem is that we still don't know what high force is for each individual and what high reps are for each individual, so it makes it difficult. Keyboard activities, if they like it split or not, fine. Ergonomic keyboards don't seem to help any more than regular keyboards. That study's been done. Trackball, trackpads may help some people. Typing breaks, insufficient evidence, but I usually recommend that. Return to work programs, I think, are very important to do. Algorithms. So if you look through the process, and this is easier in the book, and it was very difficult to get on any sort of slide pattern for you, it basically looks at the length of time, red flags, do you see those, and what are your steps? And so as you look at that and you get to the red flags would be, is there a fracture, is there an infection or some sort of inflammation type process, is there neurological or vascular loss? And then these were the steps that you need to go through that process. So moving to the cases. Pain in the wrist. So you have somebody who is on the telephone taking information. They complain of pain in both wrists for several months. She thinks that she might have carpal tunnel. She works as a receptionist at a law firm specializing in workers' compensation case. I put that in for just a little extra humor. Her job includes typing when not answering the phone. She states her wrists hurt. She wakes up at night with her hands asleep, all 5 fingers. It's better when she moves and massages them. On physical exam, there's some tenderness to palpation over the volar wrist, that would be on the flexor crease side, and the base of the thumbs. There's full range of motion of the wrist and hands. Her Tinel is positive. In other words, she says it hurts when you tap there. Her Phalange is positive. Her Durkin's test was not done. Her cat's hand diagram shows marks all over the hand's forearm, all the way up to the elbow. What else would you like to know at this point? Well, she's 35. She has a past history for these items. She has a family history for a father with diabetes and arthritis, a mother with diabetes, chronic renal failure, and on dialysis. And these are her current medications. Her vital signs were reviewed here. Now, at this point, we did an additional Durkin's test, which was described as no paresthesia. Her sensory examination was normal for monofilament and vibration. She had normal ab and adduction, flexion and extension with regard to the fingers. Radial pulses were full and equal. Her elbow exam was normal, full range of motion of the neck without symptoms. Additional testing was done. Some of you may ask, what is an EAST test? This is basically where you have them lock their hands behind their head, and then they swing their elbows out and back, and it's a way to test for thoracic outlet type symptomatology. It is not a very specific test, and frequently patients will simply say, yes, this hurts, and that's because they're not very flexible, and they give you symptoms. So when it says positive here, it would be positive in the response, but not in the actual objective findings. Her job duties, answering the phone, using a headset. She types about 30 words per minute, about 20 minutes per hour between calls. So she's obviously not typing constantly. Workstation ergonomics, her wrists are at 90 degrees. The elbows are, her wrists are neutral and her elbows are at 90 degrees to the keyboard. So she's in a traditional perfect alignment. Her wrist rest was provided. She has a soft touch keyboard. Her ergonomic workplace was looked over. She feels overburdened, though, in the process. She has supervisor relation issues. Attorneys shout at her all the time. They ask her to do multiple documents. Her direct supervisor is not happy about her work activities and habits. Co-workers characterize her as chatting. Does this patient have carpal tunnel syndrome? Well, you need to look at the history, the physical examination, the clinical maneuvers, and diagnostic testing. What would you propose for treatment at this time? In 2 weeks, 1 month, 3 months? And we're going to go through when we get to the CME questions here in a little bit and go over those processes. Physical therapy, in the process, if you looked at a wrist sprain strain and they had a therapy component, if you are the physician and you're being asked, they have a wrist sprain strain, they've had 12 weeks or they've had 12 therapy visits, do they need more? Is it beneficial? Are you going to pre-certify that? Well, obviously you need more information. You need a history of physical examination and you need diagnostic testing. Frequently you're asked whether or not a treatment is appropriate, but you're not given all the information to answer the question. So in that process, manipulation, pain in wrist, dropping things, misalignment on palpation. The question is, should manipulation be continued? And again, to do answer that question, you need to understand the history of the physical examination, the diagnostic testing. And you can go through the process. So another pre-certification request. Endoscopic carpal tunnel. They're 1 week post. Are you going to authorize carpal tunnel surgery after only 1 week? They still have wrist pain. They complain of weakness and grip. ACOEM guides would say no. At 1 week, you don't do carpal tunnel surgery endoscopically. So if you were the physician being requested to pre-certify this, in this case, you would say doesn't meet the criteria. How about at 3 months post? Still having pain in the wrist, entire thumb numb, better with motion, weak grip strength, nerve conduction studies were done. Patient's diabetic, she's pregnant. Her OB/GYN physician did okay her for a carpal tunnel surgery outpatient basis under local, and she's had 35 physical therapy visits. Are you likely to tell her if she needs more therapy visits prior to authorizing her surgery? What would the guide say at this point with regard to the process? And again, we'll get to the question. Distal radial ulnar joint. This is the end of the radius TFCC component. They're 3 months out, still having pain. They're tender over the distal radial ulnar joint. They have weakness. Their MRI shows that they do have some ligamentous laxity or change with regard to the wrist joint. Are you going to authorize injection, splinting, or surgery for this person? And again, if you're going to answer that question, you need to understand the history of the physical examination and the diagnostic studies. Okay, so that moves us through the process to the question and answer session. And in order to qualify for CME, we have 5 questions for you to consider. Oh, somebody just bumped me off. I'm trying to get back to where we were. Okay, here we go. All right, question number 1. And I'm going to read these to you. Which of the following describes the relationship between carpal tunnel release, operative approach, open versus endoscopic, and average lost time? A, greater lost time with open approach. B, no difference in lost time. C, greater lost time with endoscopic approach. I believe the answer would be B, no difference in lost time. We talked about the complication rate being higher for endoscopic than open. We talked about open being mini palm versus the traditional open technique. If you were going to do the traditional open compared to the endoscopic, then I would say that probably endoscopic would allow for less time off work. Number 2, a 45-year-old male construction worker has numbness and tingling nocturnally in the thumb, index, and middle finger, with awakening 2 to 3 times a night going on for the past 2 months. After completing a history and physical examination, which does not alter the clinical assessment. The question's a little toughly worded, but basically what they're saying is, you've made a diagnosis, you've looked at the history and information, nothing is different or outlying that would give you a concern. What would be the next step? So based on the guides that we went over, non-steroidal anti-inflammatory, splinting, iontophoresis, glucocorticoid steroid injection, or electrodiagnostic testing. Probably electrodiagnostic testing would be the reasonable next step, because we talked about the fact that if you do the steroid before the injection, you may alter the not uncommon that these patients have been seen by their primary care physician and they've had the steroid injection before you do the test. Question 3. A 35-year-old female assembly line worker has volar tingling and numbness in the median nerve distribution. She is obese but does not have diabetes mellitus. She has a presumptive diagnosis with carpal tunnel and was initially treated with a wrist brace. 2 months later, symptoms have returned. Which of the following is the best treatment option at this point? Let's assume that she has had a nerve conduction test at some point by her primary care physician prior to going through this process. And so if she's had the nerve conduction study test, the next option would be C, to do the steroid injection. And number 4, a patient has surgical fixation of a scaphoid fracture. Which of the following describes the risk of a subsequent osteoarthritis compared to non-operative treatment? This question's worded a little bit difficult, in my opinion, in that what they're really, I think, asking is, if you do not treat the scaphoid fracture, if you would allow the natural history or course to occur, which would be non-operative treatment, what is likely to happen? And what is likely to happen is, based on our current understanding, is their risk for arthritis will increase. The whole purpose in doing the surgery is to try to decrease the risk for arthritis from surgery. So which of the following describes the risk of a subsequent osteoarthritis compared to the non-operative treatment? So the answer would be A, you're going to reduce the risk if you do the surgery. And number 5, a 56-year-old male mechanic who is otherwise healthy has triggering of the right middle finger. Which of the following is the best intervention? A, workplace restrictions, nonsteroidal anti-inflammatory, steroid injection, percutaneous surgical release. I would, in this case, educate the patient. I would recommend nonsteroidal anti-inflammatories, and I would probably do a steroid injection. If you look at the ACOEM guides as far as which one has the highest recommendation, the answer is C. Although the question would be, in my case, do you do that on the first visit, or do you do A and B, have them return, and then on the second visit do C? So, answering the question according to the ACOEM guide recommendations, I would consider the answer to be C.
Mark, we had a question along the way which dealt with CRIPS, complex regional pain syndrome, even though that isn't in the hand, wrist, forearm chapter. It's in the chronic pain chapter, but it was asked, so the question was, what resources would you recommend to help to appeal denials and delays for treatment of CRIPS following a severe hand crush injury? Therapy denied despite hand being severely stiff.
Well, the first thing that I do is I like the AMA Guides 4th edition for the criteria of what is or is not CRIPS. And so if they meet that process and go through all of those items and they fall within the AMA Guides as having chronic regional pain syndrome or CRIPS, then I will be fairly aggressive in trying to get that individual seen and evaluated for the symptoms. What I would like to see is if I'm having trouble with the insurance carrier and they don't want to authorize, I will oftentimes say I would like to see the patient have 4 therapy visits and be reevaluated. And so if they come back at the end of the 4 visits and they look at me and they go, you know, it's no better, I'm worse, then I think the answer is yes, they may have some residual reflex sympathetic dystrophy, CRIPS type component. They're unlikely to get better. Investing more time in doing that is not appropriate at this time. If they do those treatments and they get improvement in the process, then I think it's reasonable to extend that for another 4 to 8 visits. 12 is usually my maximum. I think that the best thing to do is to actually encourage the patient back to regular activities as quickly as possible, explaining to them that yes, they will hurt, but the more they use it, the better they'll do. And most therapy for CRIPS is predicated on the concept of trying to use the extremity maximally.
Thank you. Now, I noticed that you said 4th edition of AMA guides and not 5th. Would you care to explain why?
Well, I think the 4th was, it's a little clearer, and the indications and criteria are clearer in the 4th than they are in the 5th. Although 4, 5, and 6 are all pretty much the same as far as the criteria, I find that the authors of the 4th were a little bit more succinct in outlining what to measure and how.
Well, it looks like our time's almost up. I don't see any more questions on the Q&A window.
No, that's all that's been submitted. Any final comments?
Just one thing while listening to your presentation, Mark, that I really enjoyed, and that had to do with the X-rays for suspected mucus cysts, where I think the recommendation was that there was insufficient evidence, and personally, I would opt for getting an X-ray, since there is a possibility that some so-called mucus cysts may be due to a bone spur, and if indeed there is a bone spur, then that bone spur is going to have to be treated rather than just aspirating the mucus cyst, otherwise it'll come back.
Yes, I agree with you completely. The studies show that if you only remove the cyst and they have the spur, it will come back. And so what I do is once the X-ray shows the osteophytes there, I've done my 1 injection aspiration, it reoccurs, and I tell the patient we'll go in, we'll remove the cyst, and we're also going to take a little bit of that bone off, and I'll take a rongeur and knock off that osteophyte. And that has really lowered my reoccurrence rates for mucoid cysts.
Question, I guess we could spend another 2 hours, which is, what about ligamentous injuries in the wrist?
Well, wrist ligament injuries are difficult to diagnose. Mechanism of injury, I think, is a very important thing to have. When the onset, when you have a ligament injury and you have an onset, I like to see swelling and or ecchymosis to give me some insight as to the severity of the injury itself. I like to do plain X-rays to see if there's any change pattern. If I think there is some carpal instability, I may do grip view X-rays, which is where the wrist is clenched and then it's radial and ulnarly deviated. That sometimes will show some widening of the scapholunate ligament, or will show some rotatory change with regard to the carpal bones. They're very difficult to read, and I'm not recommending that for general physicians in the process, but that certainly is an option to consider. And so MRIs, I think, are very helpful. Immobilizing or splinting for a short period of time is reasonable. The problem is that people continue to have chronic symptoms, and they're just difficult to get better in the short term.
Thank you. We had another question. This may be, and that was, how long after a steroid injection for carpal tunnel syndrome do you have to wait for nerve conduction studies? And I guess there are several different ways of answering that question, because if the patient responds to the steroid injection and that the symptoms go away, then you've made the diagnosis, and it may not be necessary to ever do the nerve conduction studies. On the other hand, if the patient received no benefit whatsoever from the steroid injection, then you need to consider that there's some other diagnosis going on, and in that case, you may need to do the nerve conduction studies. How do you feel, Mark?
Well, I agree with what you're saying in general, but I would say that in the workers' compensation scenario, I would probably still get the nerve conduction study, and the reason is that I am not good enough to predict in advance which patients will get a good outcome and which will continue to have chronic symptoms. And so if they're having chronic symptoms 6 months or a year down the road, and I have a nerve conduction study and they come back and I have a new nerve conduction study to compare, I find that really very helpful, because then I can say, look, your nerve conduction study was abnormal before the surgery. We did your surgery. Your nerve study is now normal. Yes, you do have symptoms, and yes, you may have some residual, and yes, we did address that with a permanent physical impairment. I don't see any additional treatment that's likely to help you. You need to stick with your exercises and do the things that we've talked about before. I do agree that having a positive response to the injection is definitely a good sign, and there's a study that shows that people who have a good response to the injection usually get a very good response to the surgical outcome treatment. And the injection may be temporarily, but they do definitely get better. As far as the length of time, most people would look at 4 to 5 weeks after the injection. If they come back and are still having symptoms, it would be reasonable to get your nerve test at that point.
Well, at this time, we does conclude today's program. We are at our scheduled time. I'd like to thank all of you for your attendance and thank our speakers both for their valuable presentation. This does conclude today's program, and you may disconnect your computer.